First of all, I thank the authorities of KPC Medical College for give us the opportunity and support, all the support to organize this program in this college. For last, we are organizing this program for last 5 years. And I like to welcome Secretary Mr. Krishna Das Madam. Miss Krishna Das Madam. Please give her a big round of applause. Principal Sir Dr. S. Bottoboyal. CMD Sir Dr. Ashok Mondal Sir. MD Dr. Saurabh Ghosh Sir. And Vice President Mrs. Swapna Rai. I welcome Dr. CEO Mr. Debojyoti Bhattacharya sir. Now I invite our President Dr. Amitava Raichaudhuri sir to say few words.
Respected dignitaries of the entire KPC Medical College team, I, on behalf of the Association of Otolaryngologists of India, West Bengal, extend my heartfelt thanks to this august institution for providing us this platform for organizing this PG orientation program and also being a part of this academic extravaganza, which is very popular amongst our PG students, and especially this is very relevant this year because 2-3 months we have spent in a different turmoil seeking for justice, and the studies and everything has taken a back foot, but now the examination is knocking at the door, and I'm sure with your support and with the support of all the teachers of the entire West Bengal Medical Education Service who have come here to spend their valuable time to share their thoughts today, we will have a good enriching 2 days program here. So I again thank on behalf of the association for being a part of this program and providing us so much of support years after years.
Thank you. I now invite Dr. Tounge Mukherjee, Assistant Professor, Medical College Hospital, to hand over the bouquet to Secretary Mrs. Krishna Das Madam. Madam, please say a few words.
So here the respected faculties from all over Bengal and the students also from all parts of Bengal are present here. We feel honored and we feel blessed also that we meet you all here. And this is for your exam orientation, isn't it? It is, I think, 4 or 5 years you are doing, but in the KPC, I think it is the 3rd year or 4th year. It is the 4th year, yeah. So already you have finished one session, morning session. I think you have benefited, is it? Yeah. Very good, and good response is there. And you also move forward with this, you have been, from lessons what you have got here and the message. And we wish you also all the best. And I also appreciate our ENT department also for organizing here. Really, I appreciate the you and your team, and I appreciate your presence. Really, we feel honored for your presence, and the students are also benefited. So I thank you all from the core of my heart on behalf of KPC Medical College and Hospital. Thank you very much, and I bless you. Go forward and do good results.
Thank you, ma'am. Now I request Dr. Devabrata Das, Assistant Professor at Arjikar Medical College, to hand over the bouquet to our Principal Sir, Dr. S. Bottoboyal. Sir, please say a few words for the students.
Good afternoon to everybody. I am very happy to be present here. But there are so many PGTs who are very well known to me and the other teachers also. And I appreciate the efforts made by the department and also the associations, because in our time there is no scope for this type of recapitulations and before examinations, this type of training. And this type of training is very important because, which is my observation, there are so many students which are very good, but during the time of examinations, they are a little bit hesitate and sometimes they are not doing better. Two things is very important for doing better in the examinations. You know, one is competent and another is confidence. So there are so many students I know, they are competent, but due to lack of confidence, they are not good in their examinations. So be aware, but try to keep up your competence at the same time confidence. If you got confidence and competence, then you will be better in examinations. I wish every success of you. You will be better in your examinations and be competent, fast this type of training, and ultimately you will get the confidence. Thank you. Thank you very much.
Thank you, sir. I request Dr. Tounge to hand over the flower bouquet to Vice President Mrs. Swapna Rai, Madam. Now I request Dr. Devabrata Das to hand over the bouquet to CMD Dr. Ashok Mondol, sir. Sir, please say a few words for the students.
On behalf of this KPC Medical College, I am very much elated that the ENT Association has chosen this place as a venue. At the same time, I am grateful as a teacher to this ENT Association for holding this type of teaching session, training session for last 5 years. I know that this place was chosen for last 5 years. It's a great achievement. I congratulate them for that reason, and also from KPC Medical College, I must say that next years for coming next year also, we will be very happy to provide this venue for this good endeavor. Thank you. Thank you.
Thank you, sir. Dr. Devabrata Das, please hand over the bouquet to our CEO, Mr. Debojyoti Bhattacharya.
I am thankful to all the faculties who have come to teach the students, and I hope that students will get a lesson to prepare themselves better for their coming examination. Best of luck for the students, and thanks to all the faculty members. Thank you so much.
Now I request HOD of ENT Department of KPC Medical College, Dr. Doipan Mukherjee, who is also the President-elect of All India ENT Association, AY. Please say a few words.
So I am attached in this hospital since 2009. So I am one of the oldest staff here, and in last almost 15 years, different ENT workshops, different ENT conferences, and the academic programs were held in this hospital, and always our entire administration was very much helpful. And I think in future also, all the programs related with AY West Bengal or All India ENT Association for any academic purpose, I hope our administration will extend their helping hand to organize all these events. And I also hopeful that these 2 days programs for the third year PG students who are going to who appear for the final MS examination in the month of December, this course will be highly helpful to face their examination. Thank you.
Thank you all. Without further delay, we will start our next session.
Now we will continue our carcinoma tongue session. The mic is handed over to Dr. Vikas Sharma. In this session, along with Dr. Vikas Sharma, Dr. Ranjan Rai Chaudhary, Dr. Indranil Pal, and Dr. Sudeep Das.
It's a post-lunch session, and I understand you must be drowsy, but I'm going to make it a more of an interactive session than a one-way teaching. So if I can have the attention of all the residents, because I'm going to be asking a lot of questions. So since I'm going to be picking up all of you randomly, and I'm going to be asking you questions, so I would request all of you to pay attention to what is going on the slide. I'm not going to be teaching you what is CA tongue. You are 1 month down the line, you've got an exam. So I'm very sure you've read about CA oral cavity very well. What I'm going to teach you is how to present a case, what is going to be asked to you, and what precise answer you need to be giving to the doctors, to your teachers. I welcome my expert panelists, Dr. Ranjan Roy Chaudhary sir, Dr. Sudeep Das sir, and Dr. Indranil Pal sir. I'm Dr. Vikas. We are doing a representative case since there is none here. So the first thing is patient introduction. We'll start from you. So I'm sorry, I do not know your names, so I'll just be pointing it towards you. So we'll start from you, sir. Patient introduction. So what all do you say in patient introduction? What all headings do you cover? And again, this is not a viva. It is not to demean you. It is to give you confidence. कि ये बोला ठीक है, क्या miss हो गया? We'll tell you what you've missed. Can I have a mic for the students? And I'll keep on going like this one by one to everybody. So please pay attention. Is that okay, sir? That's how we go about it? So when you say patient introduction, what all are you talking about?
Age of the patient.
Wonderful.
Occupation of the patient, and
bring it near.
Address, location.
So again, when you tell me something, say, I'm going to tell you, sir, the age of the patient. I'm going to tell you the occupation of the patient, or whatever you say. When we come to the history, when we come to the examination, when you utter a word, give me the relevance about it. So occupation, when I say, again, I'm going to ask you what is the relevance of occupation. So let's not waste time. So when you say occupation, sir, this is the relevance. When age, this is the relevance. Talk about it. The case is CA oral cavity, CA tongue. No, but we are talking about introduction right now. So this is all that we need to cover. And again, don't feel pressurized. If you're not answering, it's fine. You're not expecting कि आप पढ़ के आए हैं. I'm here to tell you. I'm here to teach you. Just keep on passing the mic to the next person. So please read it out aloud. What all have been said? We tell the
name of the patient,
yes,
age, because male and female we need to distinguish for some diseases, and sex of the patient, age, sex, and occupation of the patient, address of the patient, because few diseases are more common towards that particular region or particular geographic areas.
So whenever you think you want to correct them, please correct them.
Old age peoples are more prone towards the malignancy, and lower age group peoples are less prone towards the malignancy. So it's an important factor to distinguish between both of them. And religion, which is regardless of the history, sir.
So we will ask about the socio-economic status, and then
How do you quantify that?
so by asking what kind of occupation they are working on, and then by asking the average income
Wonderful.
of the family.
So essentially, what are the three components of modified Kupuswamy scale? What are the three components? Raise your hand. Raise your hand. Who knows? No mumbling. Raise your hand. Take a mic. Give me the answer.
Sir, income, education and occupation.
And occupation of the head of the family.
Head of the family.
Wonderful. So based on that, we differentiate the socio-economic status. Next.
The chief complaints.
Yeah.
Chief complaints. Ulcer proliferative swelling.
Telling a story, right? We're telling a story. We begin the story from when it began. So you start off your chief complaints, the earliest one first and the second one again. So history of present illness. So what were the two chief complaints in this case? What was the first complaint?
Ulcer.
Read what's on the slide.
non-healing ulcer over the right side of the tongue.
Okay.
For the past 6 months.
Okay.
And then pain in tongue for the last 4 months.
Okay. So you've already answered. Next. So now you've told me the chief complaint. Now you start elaborating upon the history of present illness. So good thing is, for all of you, those who've come late, I've made a model case presentation in a Word document as well, which will help you for whatever case they give you in head and neck malignancy. So at the end of it, there is a Word document. I'll hand it over to all of you. You can take it home, and that is how you need to present all your cases. That covers everything that is on the slide. So,
sir, then we describe the chief complaint. What is the ulcer?
What was the first one? Non-healing ulcer.
Non-healing ulcer.
How do you describe an ulcer?
Ulcer, the location, margin, and
margin patient. It's history of present illness. You're talking
onset,
about history right now, so no margins.
The onset, duration, and location of the ulcer, and the progression of ulcer, that it is increasing or not. And the second is the history of the pain. It is associated with pain or not.
Just talk about ulcer.
Can I interject over here,
yes,
please?
Sir, please.
Yeah. The chief complaints you had mentioned that it's a non-healing ulcer. I'm talking to the previous candidate. Roughly when do you call it non-healing?
I have an aphthous ulcer. So you understand, sir, question? I've got an aphthous ulcer in my mouth. Is that malignant? Should I be worried about it?
No, sir.
There comes a point when I will say, oh, this is alarming. This is not an ulcer anymore. So sir's question is, when do you call it a non-healing ulcer? At what time frame?
Not relieving by taking medication, conservative treatment.
Not relieving by?
So not relieving by taking medication or any conservative management, and it is progressing.
How long?
Duration is more than 2 weeks.
Wonderful. Very good. Very good.
So we've covered its progression, we've covered how it began, we've covered where it was, sometimes how it came about. What was the first incidence, how it came about. For some people it would be a slow onset, for some people it will be post-traumatic, right? For people who have no addictions, they will always have this history of trauma. And the last one is associated with whatever. In this case is pain. So then we go on to pain. How do you describe pain?
Sir, again the onset.
Keep the mic near to your mouth. So we want everybody to hear, right?
Sir, again the pain onset, duration, whether it's a dull aching or a sharp shooting pain, progression, any aggravating or relieving factor for the pain.
So in any case, what kind of pain are we looking at when there is a lesion in the oral cavity? Back of our mind, we all know the diagnosis, right? We are dealing with CA tongue. So what kind of pain are you expecting in this patient? The questions will always be directed. How will you direct the case? Once you know ki hai kya?
So dull aching pain, continuous dull aching pain because of the ulcer. Which is...
What else? Anybody else would like to better qualify this answer? Read it out.
So
if I can just, so pain, if you suspect a malignant ulcer, do you expect it to be painful or do you expect it to be painless? The problem is if you have so why do you get pain in a malignant ulcer? Normally you'd only get pain in a malignant ulcer if it was involving a nerve.
Yes, sir.
All right, but in the oral cavity, the difference is you're continuously taking things in. So food and drink on an ulcer can cause pain anyway. So pain by itself is not necessarily always has to be there for you to say it's malignancy, but also it doesn't necessarily have to be painless. So in oral cancer, pain is not, it can be there, it might not be there.
In fact, an intermittent pain, it does not indicate nerve involvement. A persistent kind of pain is more indicative of nerve involvement.
So if you got a more persistent pain, so come to the point, so the second last point.
Radiating.
So by and large, you'll be dealing, so you need not take photographs or videos. I'm going to give you this presentation. Not only in PPT format, I'll give you in a Word format as well. So it's with you. So, radiating. So what is the pathway of rhaphadotalgia?
Sir,
Glossopharyngeal nerve. Glossopharyngeal nerve.
Glossopharyngeal nerve. And you said that because?
Sir, the tympanic plexus, there is a nerve, branch of the glossopharyngeal nerve which radiates there, and the
Okay, so
anterior
see,
part of the tongue is also supplied by the.
Okay. What is the pathway of referdotalgia? So the answer is simple, right? It is, where is the lesion? Lesion is in the anterior part of the tongue. If I was dealing with base of tongue, my heading would have been CA oropharynx. We are dealing with CA tongue, right? So tongue is supplied by lingual nerve. So the pathway is, it goes via the lingual nerve, part of, and then comes back via, what is the efferent? Afferent is lingual nerve. The efferent, where it comes back from, is the auriculotemporal nerve. Both are branches of trigeminal nerve, mandibular branch, right? So that's the pathway. You should always know that. Sometimes these pathways will change when, by and large, the nerve is going to come back via the auriculotemporal nerve or the Arnold nerve. She said glossopharyngeal. Yes, sometimes that will happen. Glossopharyngeal will happen when the lesion goes to
posterior 1/3 of
the base of tongue, because that is where the glossopharyngeal nerve supplies, right? Something in the epiglottis, something in the base of tongue, so the pathway is changed. If we were dealing with CA oral cavity, if I was talking about mandible, then the pathway would be via inferior alveolar nerve. The efferent would then again change, right? The afferent would change. So you know how to describe the pain. So the patient has already told you two symptoms, but whenever you are dealing with the head and neck malignancy, there are certain cardinal symptoms that you need to ask to the patient. Those are symptoms that you can never miss in a history taking. So the cardinal symptoms of head and neck malignancy are, the next person.
Sir, cardinal symptoms, there is an ulcer.
Ulcer, wonderful.
Opening of mouth, is there any trismus or not?
Opening of mouth, okay, it's not a cardinal symptom. It may not be present in some, let's say it's not going to be present in larynx.
Right.
I said head and neck malignancy, right?
Pain around the ulcer,
Pain around the
ulcer.
Ulcer, okay. That's not a cardinal symptom. What else?
Then bleeding from the ulcer.
Bleeding from ulcer.
Then
what else? Anybody else?
Movement of the tongue.
Neck nodes. Swelling in the neck. So the cardinal symptoms that we have to ask all these patients are, if there is a non-healing ulcer, see, it's going to be present in all the oral cavity patients. If there is dysphagia, if there is odynophagia, the patient will have pain while swallowing food. If the patient has got dyspnea, now the dyspnea may happen in CA supraglottis, may happen in CA larynx, may have CA glottis, may happen in CA oropharynx, right? Neck swellings, and last, speech or voice change. So this is very, very important. The cardinal symptoms have to be asked for. But apart from that, what positive history have I missed? Have I not still asked? Next person.
Sir, dysphagia and odynophagia, this in case.
Already covered, right? Beyond that. No, beta. We are still in the
movement of the tongue.
We are still in the history of present illness.
Okay.
So we do not want to miss out on anything.
Okay. No. Sir, difficulty in swallowing and tongue movement of the tongue.
Dysphagia, we've already done.
Then addiction.
Next. Keep on rotating. We'll do multiple rounds. Sabka number aayega. Pass. Either answer or pass. It's fine.
History of any sharp tooth.
History of sharp tooth. Okay, so we've gone to etiology now. Right? That's etiological history. We'll eventually come to that. Right now we're talking about symptoms.
So any history.
So, if the patient has got, let's say he was saying ulcer. A patient has got some amount of ankyloglossia. If the patient has, so there will always be certain amount of dysarthria. You have to understand, what am I talking about right now? We are talking about CA tongue. As soon as you talk about any particular organ, you have to say, iska function kya tha? What is the function that I have lost? Right? So oral cavity ka function kya hai? Speech. If there is a tongue ulcer, if there is a pain in the ulcer, if there is ankyloglossia, what is the patient going to lose? Speech, a clarity in speech. Second is hypersalivation, because the swallowing is affected. Next, halitosis, because the microenvironment of the mouth has changed. What next? Then, because the patient has certain amount of odynophagia or dysphagia, what is going to happen? The intake is going to go down. And then there will be change in weight. right? So as soon as the patient says, I've lost 5 kgs, don't think about metastasis. Obviously, everybody who's got pain in the mouth is not eating food. He's losing out on some weight, right? So everything is not metastasis. What is next one? पढ़ के बताओ. पढ़ो and relevance बताओ.
Restriction of the tongue movement.
Restriction of tongue protrusion. That happens because
Base of the tongue involvement.
base of tongue involvement or
Sir, pterygoid muscle involvement or intrinsic or
Pterygoid.
extrinsic muscle involvement.
floor of mouth involvement,
Floor of the mouth involvement.
of the extrinsic muscles of tongue or base of tongue involvement. Then we come to complaints of
Excuse me, I would like to interject. The base of the tongue is an immobile part of the tongue. So involvement of the base of tongue will not hamper the protrusion of the tongue. Only the anterior 2/3 is mobile. So involvement of the extrinsic muscles of the tongue indicates or is indicated by lack of protrusion of tongue. Next question would be, what are the extrinsic muscles of the tongue? Can you list them out?
one of you. What are the extrinsic muscles of tongue?
Sir, styloglossus, palatoglossus.
Take the mic. Let everybody know. See, if I give you a monologue, you will never remember. If you make a mistake on answering, you will always remember the answer.
Palatoglossus, hyoglossus, genoglossus, styloglossus.
Nerve supply?
Palatoglossus by if as spinal
Sir, all of them are supplied by dash except dash.
Sir. All are supplied by spinal accessory. Sorry.
Except palatoglossal, which is supplied by pharyngeal plexus. All supplied by hypoglossal except the palatoglossus, which is supplied by the pharyngeal plexus. What is the next question? What is the next topic? What is the next one? Loose teeth.
Loose teeth or gum bleeding.
Why would that happen?
Maybe involvement of the alveolar process of
Yes. So now we have started talking. So how do you remember history? So don't try to ratify it. रट्टा नहीं मारना है. याद कैसे करना है? So remember what is the organ being involved, be it larynx, be it hypopharynx, be it glottis, be it oral tongue, whatever. Function क्या है? We know the function क्या है. Second is what all does it assist in. So we know assist क्या करता है. और last क्या है? What all structures are all around it. What all can get affected. In this case, if there is involvement of the floor of mouth and it goes laterally into the mandible, so you can have all that. Next. Next. We've got only 50 minutes. We have to be rapid about it.
Sir, no complaint of loss of taste sensation.
Taste sensation because?
Sir, involvement of chorda.
Either chorda or loss of the papillae in general. Chronic inflammation. Next.
Sir, no history of swelling or lump in any other part of the body.
Why is that important?
Sir,
how does that even make sense?
Indicating metastasis to other. No metastasis.
Not really in this case. See, I know there is a lesion in the tongue. I know there is an ulcer. We do not yet know the diagnosis. Am I dealing with a minor salivary gland tumor? Am I dealing with a lymphoma? We do not know. So you have to rule out certain things in your history as well. What next?
No history of fever, jaundice, difficulty in breathing, and recent onset of bony pain.
What does that tell me?
There is no history of any metastasis to any other organs.
Wonderful. What next?
No history suggestive of other complaints related to ear, nose and throat.
So at the end of it, you are giving an MSc NT exam. So do not stop yourself in oral cavity alone. If you've got a patient who's got, let's say, CA oral cavity, may have a perforation in the ear. So don't miss out on that. Don't miss out on the basics. Right? So ask about the relevant history as well. So after this, relevant past or medical history. What would that include? Next.
Any chronic disease of oral cavity or nasopharynx?
Chronic illnesses. Why? Because I am worried about?
Systemic.
Or any chronic illness. Let it be TB, let it be asthma, let it be hypertension, let it be diabetes. What am I worried about? Why do I need all that?
Immunocompromisation.
Immune compromise.
Or
Next. Don't waste time.
chronic ulceration or
Beta, that's fine, that's fine. You've told me chronic illness हो सकता है, but why do I need that history? Why am I asking the patient कि तेरे को diabetes तो नहीं है? Why am I asking that? Yes, because I have to make him PSC fit. I have to give him some medication. I have to give him some therapy. I have to make him fit, na? I need to know if the healing is going to be well. I know if the patient is going for a curative intent or a palliative intent. I need to see the general status of the patient. I need to see if the patient has got like 3 stents, if the patient got history of MI, if the patient has got something very comorbid. So what would happen? Obviously my intent changes, right? Next. One more thing. History of repeated trauma. Sometimes the patients, these patients who've come to you with tongue ulcers, they'll keep giving a history of tongue trauma by your teeth, having gone to the dental OPD multiple times, having sought some treatment to no avail. Do take these histories, they are relevant. And before I go on to the next one, sir, anything in this subhead? Surgical intervention, obviously important. Am I dealing with the primary lesion or am I dealing with the recurrence? See, oral cavity, if you do a wonderful job, 30% of them are going to come back. So always ask if there is some history of relapse or recurrences, right? Personal history. Now this is the most important thing. Who's got this question? You've got difficult questions ahead, huh? Right? So personal history. What all do I need to ask and why?
Personal history, because in our India, the Erica nuts and betel nut chewing has some connection with the.
So I need to know about etiology, addictions. So one is addictions. What kind of addictions am I looking at?
Betel nut chewing.
Betel nut chewing, tobacco chewing. Second,
smoking.
Smoking. Third,
Alcohol.
Alcohol. Next. So when I say smoking, how do I quantify it? What is pack years?
Sir, number of packs of consumed per day.
Per day. Considering?
For 1 year.
For 1 year.
Total.
For your lifetime.
Yes.
Number of packs into your number of years that you've smoked cigarettes for.
Yes.
How many cigarettes in a packet?
10. 10.
10. So you'll have a lot of books that give you different answers. 20, right? 20. There is a recent concept people have now started talking about BD pack years. So there's 15 BDs per packet. So if some examiner starts to ask, so you should know the answer. 15 BDs make a 1 packet. So BD pack years is also relevant, right? So pack years. Second, whatever I asked about, mechanism of carcinogenesis. Who's the next person? How does smoking cause cancer?
There are many benzopyrenes and aromatic hydrocarbons.
Aromatic hydrocarbons.
Which induce malignant.
What is the other thing you said?
Benzopyrenes, carcinogens.
Benzopyrenes, benzene rings.
Benzenes.
Or nitrosamines, which cause cancer. How do they cause cancer?
Sir, they lead to destabilization of the oncogenetics of the cell, which can lead
genetics of the cell. So, okay. Trick answer. Always remember, whatever question your examiner is going to ask, answer will remain nearly the same. Nearly the same. How? Whatever carcinogen you are dealing with eventually has to do something in your DNA. What's going to do? Is going to cause the repair of the DNA is going to get affected one way or the other. It will either form DNA adducts or it will cause suppression of tumor suppressor genes or activation of the oncogenes. 3-4 लाइनें याद करनी है. The examiner is happy with this. If you're doing well and somebody asks you, और क्या? So you knew the answer. Genes में क्या होता है? There is either amplification of gene, or there is deletion of genes, or there is translocation of genes, and that's it. So amplification of all the P genes, deletion of all the Q genes. That's how. So by and large, you know how the mechanism of carcinogenesis. What is the mechanism of carcinogenesis? How does alcohol help?
Sir, it has a synergistic effect with the tobacco.
Wonderful, but how? Does it itself cause cancer? So if somebody was taking alcohol alone without tobacco, there is no synergism. Alcohol, so will he have cancer?
So
may or may not?
May not.
Why?
Sir, alcohol actually acts as synergistic effect with smoking, but alcohol can alone cause mutation of genes.
Yes, it does. Eventually everything does. But how? Eventually everything will do the same thing. But kaise?
Alcohol will cause erosion of the oral cavity mucosa and that will...
Next. Who knows the answer? Tell me. Wonderful. So he says the bacteria has now been converted into ethanol has been converted into alcohol dehydrogenase. Eventually, see what is happening is it's a solvent. It is acting as a solvent. So it's going to convert everything into acetaldehyde or formaldehyde. Now this formaldehyde is the one which is going to cause DNA damage. So that is how it causes a that is why it has the synergistic effect. There is a more absorption of the carcinogens. So these nitrosamines that you are dealing with, these NMDAs that you are dealing with, the NNN or NNK that you are dealing with, they get absorbed a little bit more. That's all. And while chewing tobacco, how does chewing tobacco cause cancer? Who's next? How does chewing tobacco cause cancer?
Because in tobacco, some of the carcinogens are present.
So nearly the same. The same nitrosamines, the same aromatic hydrocarbons, except in chewing tobacco, sometimes you'll also have supari or tamul. So there is physical injury. Sometimes because of that, repeated traumas. So see what happens is, every time the mucosa gets injured, it's going to repair itself. Once, twice, thrice. So each time this keeps on happening, you're going to accumulate some defects. And eventually what happens? There's DNA damage. And it's going to, the mucosa becomes dysplastic and eventually becomes carcinogenic. Next. Okay, wait. Sir, so we've covered the most important and it's one of the most relevant parts of the head and neck malignancy history that you have to be dealing with. So be very, very thorough about it. So now this patient has history of tobacco chewing and intake of betel nut, but no history of smoking or alcohol. We do not talk about general examination here, we already know, but what is important that you have to say is the performance scale. So what is the performance scale? What are the performance scales you are aware of? Who's next? हाथ खड़ा करो जिसको आता है. खड़ा करो, बताओ.
Karnofsky, ECOG, Lansky, and Zubra.
Now this may also come as a short note or long question, so read about it. How do we remember it? They work in the opposite direction. So somebody who's Karnofsky 100 means is absolutely fit. Somebody who's ECOG 0 is absolutely fit. On the other spectrum, Karnofsky 0 is dead. And ECOG 5 is dead. So the things change in between that. How do you remember this? The secret lies in this 50%. 1 is perfectly fit. 0 is perfectly fit. 1 is who's got a little bit of disability. Now from 2 and 3, how do you differentiate? Remember this word 50%. Somebody who's ambulatory less than 50% of the time or more than 50% of the time. 50% time of the day वो चल रहा है, अपना ख्याल रख पा रहा है. So his Karnofsky, he is ECOG 2. More than 50% of the time, आधे दिन से ज़्यादा he is on the bed. He's become ECOG 3. And then if the patient is completely disabled, he becomes ECOG 4 and 5 becomes dead, right? So it's very easy to remember. Also, when you're dealing with Karnofsky, when we are dealing with disabilities, at what level do we say disabled hai? 40%. So 40% is disabled, right? Vitals, you should know, talk about them. Now, how do you talk about the patient? Now, the first thing that you talk about in local examination is inspection. So somebody inspect and describe this lesion. You are next or you are next? Describe the lesion.
It is a, so you have to describe the color of the lesion.
जोर की बोलना है.
So we have to describe the color of the lesion, the margins of the lesion, the surface of the lesion.
देख बेटा. Again, this is where you will lose out on. Do not jump in. When I say tongue, don't jump onto the tongue. Tongue देखने के लिए क्या करना पड़ेगा? Mouth opening. Tongue देखने के लिए क्या देखना पड़ेगा? Teeth. Staining तो नहीं है. And then you go inside and then you start talking about the tongue. Read it out so that everybody can learn. So that is how we'll save time. We'll read it out faster. Read it out louder.
Oral cavity, poor orodental hygiene. Mouth opening, you have to see
Poor
whether
orodental hygiene, we understand. These people are more prone to be having malignancies, right? Next.
Mouth opening adequate or not.
Yes.
In the tongue we have to inspect.
Why should somebody not have an adequate mouth opening? When there is? When there is, he says fibrosis. That is fine. What else? when pterygoids are involved. That's fine.
Any inflammation? Pain, sir. Pain.
ऐसे हाथ खड़ा करके खड़े होके जवाब.
Any pre-malignant condition? Any pre-malignant condition which can cause trismus?
Inflammation. Any inflammation of the buccal mucosa may cause.
Pain. So what do you mean to say? Sometimes because of pain. That's fine. So pain हो गया, fibrosis हो गया. She said pterygoids. What else? Masticator space. T4B. Masticator space involvement. Right? Remember that. So now in inspection,
Inspection, you have to
you talk
see
about the size.
Size.
है कहाँ पे? Once you say है कहाँ पे? Look at me. When you say है कहाँ पे, then you start describing about its relation to the surrounding things. क्या लिखा है वहाँ पे? Talk about it. Talk about it. Read, read.
Ulcer proliferation, reason right lateral border of the tongue.
Your voice is too low. तुम बोलो.
Ulceroproliferative lesion present on the right lateral border of the anterior two-third of the tongue.
Unfortunately, tongue is a mobile structure. So how do you know कि कहाँ पे है? So we start talking about something that is immobile. बगल में क्या पड़ा है? We've got the tooth. So I can tell कि यहाँ से लेके यहाँ तक था. Approximate idea. Then you start talking about
Anterior to, from the level of first premolar anteriorly to last molar posteriorly. Anteriorly 2 centimeter from tip, posteriorly around 2 centimeter from circumvallate papillae, medially short of midline, and laterally gingiva labial sulcus is free.
So all of them carry significance. Tip involvement, my reconstruction changes. Base of tongue involvement है, my surgery changes. Floor of mouth involvement है, the extent of my surgery and my reconstruction changes. Midline involvement है, so what changes? Neck dissection changes. Reconstruction obviously, so the neck dissection changes. So every word that you utter has got a deeper meaning. What is next?
The margins of the ulcer is irregular.
Okay.
The bed of the ulcer is pale with granulation tissue, everted, rolled out edges, yellowish white slough, and tongue protrusion is normal.
So when you got a traumatic ulcer, how does that differ? It's going to have a punched out appearance. Chot laga, दांत गया अंदर. It's going to have a punched out appearance. But once you're dealing with something like a malignancy, so the tissue is growing from inside. So eventually the edges become everted. So that's how you remember, right? And lastly,
the tongue protrusion is normal.
So no ankyloglossia. See, some doctors, while you're giving your vivas, are very particular about this. Do not use medical terms. So sometimes you can say no ankyloglossia, sometimes say the tongue protrusion is normal. So whatever the examiner is wanting out of you. Palpation, next. More importantly, palpation mein what is present, apart from inspection, what else are you looking for?
Induration.
Induration, wonderful. I'm looking for the third dimension. I'm looking for the third dimension. Remember, so what I'm teaching you is small tricks what you need to show to your examiner कि मुझे आता है. Because eventually he's going to go to the TNM classification. So what are you looking for?
TNM classification.
The third dimension. How are you doing that? By looking for induration. What else?
Sir, tenderness present over the ulcerated surface. A single oval ulcer proliferative growth of size 3 centimeter into 3 centimeter into 1 centimeter in the right lateral part of the tongue, extending 2 centimeter posterior to tip of the tongue up to 2 centimeter anterior to sulcus terminalis. Irregular and rough surface, firm in consistency, anteriorly well defined margins and posteriorly ill defined. Does not cross the midline, everted and rolled out edges, irregular margins, base is indurated. Floor has pale granulation tissue with yellowish.
So by and large, everything that we've already covered, right? Because that's going to change my management plan. Now, second primary malignancy. Oral cavity में lesion है. Am I done? Oral cavity में lesion दिख गया. Do I need to examine further, or that's enough? The upper aerodigestive tract. I see an ulcer in the oral cavity. Should I go and start treating the patient for oral malignancy? What is second primary malignancy? One of you take the mic. Why am I looking at the other subsides? Why am I looking at endolarynx? Why am I looking at hypopharynx?
Fiber-optic laryngoscopy has to be done to inspect the complete upper aerodigestive tract. And second primary is a lesion which is a lesion which is pathologically similar to the primary lesion and is not a metastatic Warren Gates criteria. The second primary is a secondary lesion which is pathologically similar to the primary lesion, and it is proven that it is not a metastatic lesion of the primary lesion and has a normal mucosa intervening the two lesions.
It should be around 2 centimeters away. It should come 3 years later. It
3
should
years
have
later
a
or-
different anatomy. It should have a different malignancy. It should be a different malignancy altogether, right? So that's Warren Gates criteria. Sometimes the examiner might ask, hence we need to look at other subsites. I should not be looking at a second primary. There's another lesion in the hypopharynx. मैंने CA tongue hemiglossectomy किया and I'm happy about it. I should not be. I should look at the entire upper aerodigestive tract. Next, neck. What am I looking for?
We check
Just
for
a
the
minute.
neck.
So the thing to remember, if they talk about second primaries, you'll be asked what is field cancerization. All right? The whole, why do second primaries occur is because if you say that the cancer is a result of exposure to tobacco or alcohol, the whole of your aerodigestive mucosa is exposed. So all of the mucosa potentially can form a malignant lesion. That's why the one that appears first is just the area that was affected most. You can have an appearance of a lesion anywhere else in the exposed area. That's the whole point of looking for second primaries.
It can be a long question, it can be a short question. The question is field carcinogenesis. The molecular mechanism of carcinogenesis and field carcinogenesis may be a question. So, theory by?
Slaughter's.
By Slaughter.
Field
Slaughter's
cancer.
theory of field carcinogenesis. Essentially meaning when somebody is chewing tobacco, it's not going to stay at one place, right? The juices are traveling all over. It just so happened the malignancy appeared at one place. Doesn't mean the entire mucosa is normal. You've treated this place and suddenly you see the malignancy coming up in a separate site. Why? Because it was still exposed to the same carcinogen. It just came on later. That's all, right? So we were talking about neck. Why do I need to know about neck?
Because we need to see the nodal status, which will change the staging of the cancer.
Yes,
And
one is the nodal status for the changing because suddenly N1 makes it. Why is it bad? Why is the node bad?
because our management will change on the basis of
So
that.
it is bad for me, you mean to say.
No,
Why?
and the prognosis.
Decrease by nearly? By nearly 50%. So N0 versus N1, the survival goes down by nearly 50%. So that's very, very important. Obviously, my management changes, but I need to look at the nodes. And when I say node, how do I describe them? What are the certain essential things when describing a node I should be talking about?
So the level of the nodes, the
Level.
size of the node,
Level,
and
size.
the surface, skin surface or the underlying.
Yes. So whatever that changes the end staging. Right now we are in the examination part, right? So I'm not talking about how to examine a swelling, but when you talk about a node, node ka N1, N2, N3, what changes N1, N2, N3? The size. What else? The location. It's ipsilateral or
Ipsilateral or
contralateral. And the
contralateral.
third one is?
The
ENE,
extranodal
extension means fixation to the surrounding structures. So it's very easy to say, sir, there was a node and it was immobile. So suddenly my end staging becomes N3B. Even if it was 1 centimeter, right? 2 centimeters. So these questions need to be asked. Hard matted lymph nodes with overlying skin involvement, ulcerations, you know they are N3B, right? So somebody now summarize the case. No, okay, summarize the case.
64-year-old male presented with history of non-healing ulcer over the right lateral border of tongue since 6 months. Pain with referred otalgia to right ear, 4 months, with history of tobacco and betel nut chewing for about 30 years. On examination, a tender ulceroproliferative growth of size 3 into 3 into 1 centimeter with everted and rolled out edges. Indurated base was felt, which bleeds on touch. Hence, my provisional diagnosis is growth lateral border of tongue.
Okay, so I have put it down purposefully so that you understand bolna kya hai. Now, you've not still taken a biopsy. You do not know it's a squamous cell carcinoma. You can't call it a carcinoma yet. But you know there was a fixed hard matted lymph node. You know there is an ulcer which is bleeding on touch. And by and large, in a patient who has a history of smoking, had a history of tobacco chewing or supari consumption or whatever. So you know it's a clinically malignant lesion. So you can say my provisional diagnosis is a clinically malignant growth. It's a clinical thing. I might be wrong, right? Biopsy might turn out to be something else. So it's a clinically malignant growth of, first say the site. What is the site? Oral cavity.
Oral cavity.
That's a subsite. So first, what is the site?
Oral cavity.
Oral cavity. What is the subsite?
Tongue, right lateral border of
lateral
tongue.
border of tongue. Which side?
Right side.
Very easy. So sir, my provisional diagnosis is it's a clinically malignant growth in the oral cavity, subsite right lateral border of tongue. And my clinical staging is?
My clinical stage.
Sleepy. Staging. We're doing the circle back again. So, koi nahi, make a mistake. The best way of learning is to make a mistake. Make a mistake. Say T1, say T4. It's okay.
Neck nodes were not palpable, so N0.
N0, wonderful.
M, there was no metastasis.
Wonderful.
So
I
M0.
have not checked for metastasis. I have no idea. It is still MX.
Yeah, it's still MX. But T.
Next. वहाँ लिखा हुआ है, size लिखा हुआ है.
2 into. Oh, sir, T2.
T2 because?
Because of not more than 3 centimeter.
Not more than 3 centimeter. So 3 centimeter तो होता ही नहीं ना लिस्ट में. आएगा, तुम्हारा नंबर आएगा. Wait. Give the mic. Pass on the mic. This is very important. Whenever you are going for a head and neck case, आएगा ही आएगा. Head and neck case में सब कहाँ जाके फंसते हैं? TNM staging, which is the most basic thing. सबको आना चाहिए, but सब फंस जाते हैं. Try to rectify them.
T2.
हाँ?
T2.
T2. Why T2?
Less than 6 centimeter.
Less than 6 centimeter. So what is? Tell me the TNM staging for oral cavity. So the answer is it is T2. But why T2, beta? Sit down. So I'll teach you. Important. Ratta kya marna hai?
I would like to add a point. The size of the lesion here is actually not the size of the ulcer. It's the size of the induration.
So
that's what you'll write.
The trick is 3 into 3 into 1 centimeter. Why did I write that in bracket? Have I written down something in the bracket? So the transverse diameter is the one that is going to change everything. 2 centimeter से कम है T1 है, I am aware. Between 2 to 4 है, I am aware it is T2. Greater than 4 है, I know it's T3. What changes is the depth of invasion, right? So TR, it is the transverse diameter. इसमें कितना था? 1 centimeter. 1 centimeter becomes, so this is a trick question examiners are going to fool you with. They'll say lesion is 10 mm. Now does it make it T2 or T3? So the key point is it is less than equal to 10 mm. Remember this. If this less than equal to 10 mm is where the examiners were going to get you. वो बोलेगा the lesion is 4 centimeters. Does it make it T3 or T2? It's क्या लिखा वहाँ पे? Less than equal to. So never say the word less than. Say less than equal to. That's how you should remember. So remember when the lesion is between 2 to 4 centimeter like this, 3 centimeter है, and the depth of invasion is less than equal to 10 mm, 1 centimeter. What has it become? T2. If the lesion was greater than 4 centimeter or if it was greater than 10 mm, तो क्या बन गया? T3. और अभी latest जो guidelines हैं, it says, what if both are present together? What if it is 4.5 centimeters and 13 mm? It becomes T4A. That's the latest guideline, right? And for nodes, somebody just rattle out nodes. N1, N2, N3, N4 क्या होता है? N3 क्या होता है? N4 बोला मैंने, हाँ? Rattle it out. Mic off नहीं करना.
N1 is single ipsilateral node, 3 centimeter or smaller in greater dimension without extranodal extension. N2 is ipsilateral node, which is 3 centimeter to 6 centimeter, and one more is okay, N2A is ipsilateral, single ipsilateral lymph node larger than 3 centimeter but not larger than 6 centimeter in greater dimension without extranodal extension. N2B is multiple ipsilateral lymph node.
N1, N2, ABC?
Yes, sir.
And N3,
AB.
One is less than 3 centimeters. N2A is एक तरफ
2 to 3 ipsilateral.
N2B is multiple
and
N2C is contralateral.
contralateral.
C में लिखा है contralateral, right?
Yes, sir.
Contralateral. And everything is between 3 to 6?
2 to
Between 3 to 6?
3 to 6.
ठीक,
Yes.
वो था 2 to 4. ये क्या है? 3 to 6. Now we come to N3. N3 very easy. 6 सेंटीमीटर से अभी तक कम चल रहा था, अब क्या
Yes,
होगा?
sir.
It's going to be greater than 6
Greater than
centimeters.
6 centimeters.
Plus, what makes it more sinister? The extranodal extension. That becomes N3B.
N3B.
So this is common for entire head and neck, except nasopharynx and thyroid. So याद रहेगा? Wonderful. Sir, anything to add till now? So this is the question that is favorite of nearly all examiners these days. What is depth of invasion versus tumor thickness? Who's next? Who's next? You are next? How? So मैंने आपको जो दिखाया था, I said transverse diameter was 10 mm. What is that? Is it
Sir,
tumor
depth
thickness?
of invasion is basically the induration created by the tumor in the
Can somebody define it? Not tell me what is your interpretation of it. Can somebody define it? Okay. So what will happen? Sometimes you'll have an exophytic growth, right? Exophytic growth means there is a bulge in the diagram. So you say, so what is happening is, in this growth, there is a bulge. In this growth, there is no bulge. You mean to say this is more sinister? No, that is not how it works. How it works is, the most prominent part of the lesion, when it goes to the depth of the lesion, it becomes the tumor thickness. When you draw a plumb line from the normal surrounding mucosa basement membrane, that is usually the ulcer. अगर एक अल्सर है, अल्सर के बगल में जो नॉर्मल बेसमेंट मेम्ब्रेन है म्यूकोसा की, फ्रॉम देयर इफ यू ड्रॉ अ प्लम्ब लाइन, नाउ दिस इज कॉल्ड एज डेप्थ ऑफ इन्वेजन. नाउ व्हेन in AJCC guideline they say depth of invasion 10 mm. This is what they mean, the dotted line, the depth of invasion, not the tumor thickness. Please understand that, right? It's an important concept. So DDs will be, obviously it was a straightforward ulcer in the oral cavity, likely to be squamous cell carcinomas. What else can it be? Who's next? Mike कहाँ गया? You cannot be asleep. I might come to you randomly. Huh?
Sir, verrucous carcinoma.
Verrucous would be more finger-like. It will be more projectile. It will be more proliferative. Next is?
Undifferentiated carcinoma.
Maybe. What else?
Adenocarcinoma of minor salivary glands.
So your oral cavity is lined by minor salivary glands. Whenever you've got a lesion in any of the subsites, this becomes automatic one of your DDs. What else?
Traumatic ulcers.
Traumatic ulcers. Chronic traumatic. So traumatic ulcer I said was not malignant. But why should that be in my DD? For old people who've got dentures, no matter what they do, they're eventually going to keep on hitting, and that may eventually become the cause of cancer, right? So how do you now work up this patient? ये patient OPD में आ गया. What all investigations or what else? What all are you going to do?
So we will do indirect laryngoscopy.
Indirect laryngoscopy, बेटा.
Or
सबसे पहले, patient is in front of you, showing something in the oral cavity. The first thing we do is indirect laryngoscopy.
Sir,
Okay,
we will
okay, ठीक है, that's fine. So
plan
that's
for punch
indirect
biopsy.
laryngoscopy has already been done. Please understand, हमने बात कहाँ कर लिया वो? In the examination part. Examination is over. Now, how do you work up this patient?
So we would plan for punch biopsy or wedge biopsy.
Punch biopsy.
Yeah,
So is it
like
punch biopsy or incisional biopsy or wedge biopsy?
So wedge biopsy, sir.
Wedge biopsy, why?
Incisional. Sir, we will see the.
Sir, any of you would you like to? What would you prefer? मतलब, so it's a confusion. So there is no right answer to this. Some people would say it will depend upon the subsite that you're dealing with. Eventually, what do I require? To say it to be a malignancy and not carcinoma in situ. What do I require?
So a part of normal tissue.
No. Basement membrane. I need to see the invasion of the basement membrane. So whatever gets me the basement membrane. So usually when I am dealing with the lesion in the tongue, what will I do? I will do a wedge biopsy. I'll take some normal tissue, I'll take some abnormal tissue and take it deep. Because when I take it deep, I am also dealing with something, how deep it is, right? I want to know. Obviously, it's not going to give me the depth of invasion, but it will give me a better idea about the basement membrane invasion. So wedge biopsy is the right answer. But sometimes when it's a very proliferative kind of growth in oral cavity, any of the subsites, even a punch biopsy is going to do. So there's no wrong answer to this. So biopsy. Who's Neha? Bolo.
So before doing any biopsy, we should proceed for radiological investigation.
Okay. So a very pertinent question. पहले इमेजिंग कराऊं कि पहले बायोप्सी? शुड आई गेट अ सीटी डन फर्स्ट, कि पेशेंट को बोलूं ये सीटी का फॉर्म लो, तुम अपना जाओ सीटी करा के जब वापस आओगे तो मैं बायोप्सी करूंगा?
Sir, MR.
So she's got the right answer. So what happens is, if you're dealing with a small lesion, a very small lesion, less than some centimeter, where you know your biopsy is going to change the architecture, so you get a imaging first. When you're dealing with a larger lesion, it doesn't really matter. It's going to be there irrespective of what you get done first. So try to do it as fast as possible. So what we require before we do a biopsy is the viral markers. So eventually what is going to happen is, you're going to send the patient, get the viral markers done. By the time they come back, they're going to get the CT ka date, appointment. So everything happens simultaneously, but your answer will remain, sir, if it's a smaller lesion, I'll get an imaging first. If it's a larger lesion, whatever happens faster.
If I can ask a question.
Sir.
How deep should your biopsy be? How will you know that you have taken a biopsy of adequate depth?
Sir is asking the adequacy of your biopsy. How do you know adequate hai?
Sir, keep the sample in water, and if there is sample is sink down in the water, then no.
It's not the size of the lesion.
To
Yes.
palpate.
So when you're dealing with a necrotic tissue, what happens? It doesn't really bleed. But when you have fresh blood, you know you've gone deep enough. Sir, that was the right answer?
And it's always better to take a deep and narrow biopsy rather than a wider and shallow biopsy.
So now we've done a biopsy. What else? What? Biopsy then?
Then, sir, imaging.
Imaging. What imaging?
MRI, sir. MRI.
MRI. Why?
Sir, there is soft tissue involvement. Sir,
So sir's question is, where do you take a biopsy from? The medial aspect, the lateral aspect, anterior, posterior, or nothing matters?
lateral.
See, as long as you can get a deeper biopsy from the most representative part and some surrounding mucosa, it's fine. It can be taken from anywhere. As long as you get a most representative tissue. If you go into the center of the lesion and take out some necrotic muck, and they say nothing but necrosis is seen, it doesn't solve your purpose, because the report is going to come 7 days, 14 days down the line. You don't want to waste that time. So you take from the edge of the lesion, never from the center where it's going to be necrotic tissue, right? So this is what sir was asking.
No, not from the margin, definitely you have already told. Which margin? Lateral margin, medial margin, anterior margin?
So the preferable margin.
Sir, lateral margin.
Maybe lateral margin, most probably the anterior margin is the best.
Anterior.
Yes, probably. See, anterior margin, yes. The ease is there. You can go deeper. If there's a bleeder, you can control. And
at the same time, if the medial margin, it may cross the, anyhow you take the biopsy, the chance of escape route over the malignancy. In the medially, then you may cross the midline. Laterally may go the floor of the mouth. Anterior is the best. You can resect part.
Okay,
so, see, we are short of time now. So, again, now I'll start talking. So, CT versus MRI, which is the preferred modality?
MRI, sir.
MRI. Why?
Sir, is there is soft tissue involvement present or not?
Soft tissue involvement. So, MRI gives you a better soft tissue delineation. Also, it gives you a better idea about involvement of the neurovascular bundle. It gives you a better idea about marrow invasion. So, that is where your MRI will trump, right? But, is it okay if you get a CT done? MRI hai nahi hospital mein? It's fine. MRI is fine. MRI doesn't give you the depth of invasion. Please understand. The third dimension is not that good. The involvement of the surrounding muscles is not that good. But it's not a bad modality. Also, it trumps over MRI when you're dealing with cortical bone erosion. Right?
Yes, sir.
Then why NCCT chest? Metastatic workup.
Metastatic growth.
If I've got an MRI done and I still do not know about the bone, an OPG might help. Ultrasound abdomen, because I want to see distant metastasis. Yes. And lastly, CBC. Why? Because I have to take up this patient for surgery eventually. So we've taken up everything that is given in this slide. This is the NCCN guidelines 2024. Now management. How do you manage
I have a
this?
question over here. So we talked about NCCT, the thorax, and USG abdomen. Question is, do we do that in all cases? If no, then what are the indications for doing these?
So what is said till now is a higher stage disease, multiple nodal stations, a recurrence or a relapse case What else? A high-grade tumor. Multiple nodal stations. So these are the patients where the probability of metastasis is higher. Obviously, I'll always get a metastatic workup done for these cases. But even for T1, T2 lesions, we should not miss out on metastatic workup, at least for the chest. Maximum amount of metastasis is going to happen to the chest. Only less than 3% is going to happen to the abdomen. But a metastatic workup is a must for every case. Management. How will you manage this case? Who's next?
Sir, management in the early cancer, in the small lesion.
So we are dealing with the T2 lesion. How are you going to manage this case?
Sir, in T2 lesion there is a hemiglossectomy.
Hemiglossectomy.
Yes.
Okay.
And prophylactic supraomohyoid neck dissection.
Prophylactic supraomohyoid neck dissection. Anybody else would like to qualify it better? Wild local excision along with supraomohyoid neck dissection. Okay, what else? So, okay, understand. I'll give you the answer. We do a partial glossectomy. So, multiple, I am getting distracted. So, multiple terminologies can be used. You can call it a wild local excision with adequate margins. You can call it a partial glossectomy, or there is something called as an Ansarin classification, which gives you a better delineation of how to classify these glossectomies. So you do some kind of glossectomy. Number two, you address the neck. When you say you address the neck, although it was N0, the rule of the thumb is you will always address the neck. How would you address the neck? Neck dissection. So don't say supraomohyoid neck dissection. Say selective neck dissection. Why? See, earlier the dictum was whenever you're dealing with an N0 neck, for everything else you will do supraomohyoid level 1 to 3, except for tongue, where you will do level 1 to 4. But there are certain new papers which say skip metastasis to level 4 is highly unlikely. So simple people have started again doing level 1 to 3. But the answer is for all other subsites of oral cavity, for a T1, T2 lesion, you will do level 1 to 3 except for tongue, where you will do level 1 to 4. So am I right? And then reconstruction. How do you reconstruct? Always talk about your reconstruction in your management plan. Don't miss out on that. So I'll tell you the answer. The answer is very simple. If it is less than 1/3 of the tongue that has been resected, a primary closure would suffice. There are certain new papers which also say leave it raw, everything will be fine. There are certain papers to that extent, but your answer will be less than 1/3 of the tongue, it is primary closure. More than 1/3 of the tongue, some for kind of reconstruction needs to be done. The best, if you have the resources, if you have the know-how, the best modality is a free flap. What kind of free flap? I need a soft pliable flap here. So what is the best flap I know of? Radial artery free forearm flap. What other option?
Pectoralis major.
Nasolabial, ALT, whatever, PMMC. So you can use multiple local flaps or free flaps. Try to give answers in my institute or something of that sort. The best answer would be a free flap. Otherwise, the other options are local pedicled flaps. Something like a nasolabial flap as well, or a PMMC. Some people will also do a buccal mucosa, myomucosal flaps. You can do whatever, submental flap, infrahyoid flap, all the local flaps that you have. So additional reading, the slides is with you. So you should know Ansarin classification क्या होता है glossectomy के लिए. Types of neck dissection. So he said supraomohyoid neck dissection. I said नहीं ऐसा तो कुछ होता ही नहीं है. No, you can use those terms. Supraomohyoid neck dissections, extended supraomohyoid neck dissection. Some people will say modified radical neck dissection. 1, 2, 3. These are old time terms that people used to use earlier. Nobody uses it now. We just say neck dissections and say whatever level. So no confusion at all. See, if it was an MCH Viva, I might say, talk about sentinel lymph node biopsies, I might talk about gamma cameras, I might talk about frozen sections. It's not required. But yes, if you're talking about for your MS exam, and if you want to supplement it by saying, sir, I would also like to send frozen sections during the intraoperative phase, it's fine. It will get you some extra marks for margins. Now, since he has said margins, it brings us to the next point. Surgery kar diya, everything is fine. Am I done? Or does the patient require adjuvant therapy? How do I decide? Pathological staging, wonderful, which will include, what all am I worried about? the nodal station. So if it was N positive, I would require some kind of adjuvant therapy. If it was, what else? Margin clearance. So, okay, let's not confuse. So, what all things that you require? Number one, if the T staging is higher, if it's T3, T4, an advanced disease, you will always require some amount of adjuvant therapy. If the nodal station is N positive, you will require some form of adjuvant therapy. If you're dealing with things like perineural invasion, vascular invasion, lymphatic invasion, or worst part of invasion, that is 5, and multiple factors are present together, you will require some form of adjuvant therapy. Then some examiner might ask, chemotherapy kab dena hai? How will you supplement it? Chemotherapy kab dena hai? Only in 2 conditions. Not chemotherapy alone. I mean to say adjuvant chemoradiotherapy. So when do you add chemotherapy to your radiotherapy regime is only 2 conditions. Positive margins and extranodal extension. So remember these words. After that, so these are additional readings you may or may not do. Management of neck in oral cancers by Dr. Anil D. Cruz. What are the type of neck dissections? Sir, am I out of time, sir? Am I out of time? So these are certain additional readings that you people need to do. So this is by and large how you will manage the head and neck case. Now I will request, see my panelists are extremely, these are going to be probably your examiners, few of them. So I will, now we'll eat their head, we'll like to ask them what all questions they are likely to ask you for these patients, right? For CA oral cavity, CA tongue. Sir. Anything that we have missed, anything that you would like to ask your exam students?
Yeah, about endoscopy. So would you like to do an endoscopy in all patients or in selective patients? And why would you like to do an endoscopy? Because you had so to look for second primaries, maybe. So in oral cancers, you don't do it routinely for all cases, not in our country at least, since we are resource trained. You may do it only for smokers, but you do a targeted endoscopy. But for hypopharyngeal cancers, you need to do it for all cases. I think we are strained for time also right now.
There's just a few things. In any exam, especially if you're giving your oral, there are a couple of phrases you need to say. All right? Make sure if you're talking about oral cancer or any head and neck cancer, one phrase you should use, if you're asked about a biopsy, try and remember to say, I'll take a representative biopsy. That itself conveys that you know that you need to take a biopsy which has basement membrane and adequate depth. So there are small words you can say which your examiner will pick on. So say, I'll take a representative biopsy. All right? Say that if they ask you, how will you manage the patient? Your first answer should be, ideally, we'll discuss the patient in a multidisciplinary team. It shouldn't be just the surgeon's decision. So you just always mention we should have a multidisciplinary team to decide upon the management. And then again, if they ask you, okay, you've done surgery, will you do adjuvant therapy? You will say, patient should be again discussed in a multidisciplinary team, including the oncologist, to decide whether they need adjuvant therapy or not. All right, this is best practice. These are few words. You might not know anything about a multidisciplinary team, but mention it.
One question खूब frequently asked in exam, after resection of the tongue, wide local excision or hemi, what you called, how will you send the specimen per biopsy? Very important. Because your leveling of the direction, leveling of the side and the lateral side, medial side of the specimen is very important for the post-operative management. If there is any positive margin, or then it will be very helpful in which side your disease may recur or where you do the re-resection. Number one. And number two, regarding during the investigation, one thing you may just remember, may ask that during the depth of the invasion, clinically by the thickness and by MRI, and intraoral ultrasonography have some role also. Intraoral ultrasonography to see the depth of the invasion.
One last thing. If you're asked which will you do first, your imaging or your biopsy? Ideally, you should get your imaging done before you do the biopsy, because if you have a small lesion and you biopsy it, the traumatic, the inflammation from the biopsy will make your lesion look bigger on the imaging. But if you have a big T3 or T4, it doesn't actually make a difference whether you do the imaging just after, because you're not going to significantly increase the size. So in an ideal world, you do your imaging first, then you take your biopsy. But in our circumstances, whichever can be done quicker, because you want to get to the diagnosis quickly. Okay, good luck.
I think we're out of time now. Radiology, there was nothing too much to discuss, and I'm not going to discuss it, but you should know बोलना क्या है. As soon as somebody gives you a radiology, क्या बोलना है? This is what? This is a computer enhanced. What is this? Is a contrast enhanced computed tomography. क्या बोलना है? बोलो. Or what I mean to say is, don't say CEMRI. Say the entire term, right? So when you say this, always say, sir, this is a film with a scout film. Initially scout film hoga, and then the sections from this level to this level. Sir, I am describing a T1 or a T2 weighted image. Always remember, अगर कैंसर दिख रहा है तो क्या है? वो T1 with contrast है. Tricks. Contrast कैंसर दिखेगा कहाँ पे? T1 with contrast में. T2 में हम contrast नहीं देते. हम contrast कहाँ देते हैं? T1 में. So when you say with contrast, never utter the word T2. Say it's a T1 lesion or a T1 with contrast or T2 lesion. Sometimes the fat around will go. So say it's a fat suppressed image. So small tricks. Always say what section. Is it a axial section? Is it a coronal section? और इसमें हमेशा क्या दिखेगा? Intrinsic muscles, extrinsic muscles, the floor of the mouth, the geniohyoid, the genioglossus. When you start looking at this fan-shaped muscle, you know you're talking about genioglossus, right? If you want to score a distinction, talk about diffusion-weighted images. You talk about absolute diffusion coefficients if you want to score distinctions. So this is what you need to talk about. Then T1 versus T2 weighted image, again you can see in T1 it will be hypo-intense. T2 it slightly becomes hyper-intense. But as soon as I give contrast, what happens? Again, contrast enhancement is more visible. So T1 with contrast is what I am dealing with, right? Last, why is MRI was better? See the top soft tissue delineation here versus here. I can't hardly see anything. Plus, the artifacts are more pronounced in CT images, right? So they make us kind of blind. So that is more than enough of it. So best of luck for your exams. I thank all my panelists for their expert opinions.
Thank you.